All right, so I think we can go ahead and get started. So welcome everyone, and we're gonna both be presenting some information about IVF, and then we wanna make sure we leave time to answer your questions. So with that, I'm going to share my screen. Okay, so hopefully everyone can see the screen that I have here. Okay, so today we're going to be talking a little bit about maximizing IVF success rates, and we're really excited to have everyone joining us tonight. We know this is not an easy time, and we want to make sure that you all know that we're here for you. So we know that infertility can be a very isolating diagnosis sometimes, and you can feel alone. We want you to know you're not alone, especially in times of COVID when we're all kind of staying at home. It's hard to feel connected, and we just really want to make sure you know that we're here for you, and we're here to help. So just wanted to say a little bit about our center. So our center has been around a long time at San Diego Fertility Center. We do about 1,200 IVF cycles a year, and we're one of the largest centers in California, and we offer all sorts of fertility testing: IUI, IVF, IVF with egg donation, and surrogacy. We're going to be focusing our conversation tonight on IVF, but we definitely offer a wide range of treatments designed to meet your needs. There are 5 of us. So I'm very fortunate to have wonderful partners, and anyone who is joining us tonight, if you'd like to schedule a consultation with one of us, we'd be happy to talk to you, meet with you, and come up with a treatment plan to help you build your family. So we're going to be talking a little bit about infertility, IVF, pre-implantation genetic testing, lifestyle factors, and then taking the next step. So I wanted to talk for a moment about infertility. So what is infertility? Infertility is defined as the lack of pregnancy after 12 months of intercourse without contraception. And if this is your situation, you are not alone. This affects 1 out of every 8 couples. It's very common to struggle with depression and anxiety if you're struggling with infertility, and it's just important to know that you're not alone. There is hope, and there are many effective treatments. There are many different causes of infertility. I'm not going to go into all of them. Sometimes we can identify a specific cause, and sometimes we can't. Sometimes all of the testing is normal, and that falls into a category of unexplained infertility. So what we know is, unfortunately, as women, our biology is unfair, and that's because we're born with all of our eggs. We lose them over time, but the eggs that we're born with accumulate genetic mutations as we age. And it's really that underlying biologic difference which makes it harder for us to get pregnant as we get older. And men get to make new sperm every 70 days. That's really the difference in our biology, which is why it makes it a little bit harder for us to get pregnant as we get older. That's why for fertile couples, as women were in our 20s, it's about a 25% chance of pregnancy each month. But by the time that we're 40, it's about a 5% chance. So we know that the most fertile couples will get pregnant faster, and the longer a couple has been trying to get pregnant without success, unfortunately, the lower the chance is of a spontaneous pregnancy, because it means there's something in the way preventing pregnancy. This is the worst slide that we'll show, and this shows the decline in female fertility with age. And I know it sounds a little bit repetitive, but unfortunately, this is an important thing to keep in mind when we're talking about fertility treatment and what the best next step is. So what is IVF, or in vitro fertilization? What is the goal? The goal is to increase the opportunity for the sperm and egg to meet successfully and for an embryo to implant successfully. And we'll talk about how we accomplish that. Primarily, it's through obtaining more eggs targets, injecting the sperm directly into the egg to bypass barriers to fertilization, and then putting the embryo directly into the uterus. So eliminating challenges with the fallopian tubes, trying to improve uterine receptivity, and very importantly, what Dr. Chuan will talk about is how to improve embryo selection. So what is in vitro fertilization, excuse me. So there are several parts that we're going to talk about, but fundamentally, it involves stimulating the ovaries so that multiple eggs grow. These eggs are removed with an egg retrieval. The eggs are fertilized with sperm, and embryos are grown in the lab, and then subsequently that embryo is transferred back to the uterus. And we're going to talk a little bit more about each one of these steps. So in a natural menstrual cycle, the ovary recruits a group of eggs, and from that group, only one is selected to be released through ovulation and the rest are lost. Like we talked about, it's not a great system, unfortunately. So in a natural menstrual cycle, you see that there's one egg that's recruited. In an IVF cycle, we're saying, hold on, don't pick one egg. We want that whole group to grow this month that would have been lost anyways. So consequently, we are not impacting future fertility. We are not taking eggs from the future. That's a common question that we get. Also, sometimes we get questions on natural IVF or do I need to take medications for IVF? Well, if a woman does not take medications, unfortunately, the maximum number of eggs we could get from an egg retrieval cycle is 1. That's why we use injectable medications to increase the number of eggs that develop. As we discussed, this does not accelerate ovarian aging. And also importantly, it does not seem to increase the risk of breast or ovarian cancer. There do not appear to be downstream adverse health impacts from taking these medications. So for women that are older, we do use what we call adjuvants. So these are helper medications, sometimes oral medications and injections designed to help maximize egg and embryo quality. So we really want to come up with an individualized protocol for each patient. It's not one size fits all. It's not cookie cutter. We really want to look at a patient's history, their lab tests, look at the whole picture holistically to know, okay, well, what is the best treatment protocol for this patient? And I just want to mention for a moment, we were going to be talking about IVF, but some of these things that we're talking about in terms of stimulating the ovaries, this holds true if a woman is freezing her eggs. There's also a lot we can do in terms of fertility preservation with egg freezing or embryo freezing. So we're just focusing right now on IVF, but as I mentioned, there's a lot of different paths to building a family, and we're happy to answer questions that are specific to you. Sometimes we get questions on what's called hyperstimulation syndrome or OHSS. And fortunately, this is really a thing of the past in the sense that the protocols that we have now, the trigger injections, what we call a trigger is that last injection that a woman takes to that final step in getting the eggs ready for retrieval. If we can avoid a medication called HCG, the risk of hyperstimulation syndrome is very minimal. So we have very closely designed and careful protocols in place to make sure that the IVF cycle is as safe as possible, as effective as possible. And a big part of this is using what's called a Lupron trigger instead of using high doses of HCG like we used to do in the past. Another protocol change has been that we're really not doing fresh embryo transfers, we're doing freezing of embryos, and I'm going to talk more about that. That's when we're freezing an embryo and transferring it at a later stage. So how do we get the eggs out? So the eggs are retrieved with a procedure as if I'm using a needle like for a blood draw on the arm, but instead it goes through the wall of the vagina into the ovary to take out the eggs. When we do that, it takes about 15 to 20 minutes. The woman wakes up and go home the same day. It's normal to feel bloated and crampy, but most people are able to go back to work the next day. And like I said, it's under anesthesia, so you don't feel any discomfort. So previously, what we used to do was to place the sperm on top of the egg and allow fertilization to occur on its own in the lab. That was what we call conventional fertilization. Now, what we do is do ICSI, intracytoplasmic sperm injection, and that's when we're selecting the most normal appearing sperm in the lab, injecting one sperm into each egg, and then that helps maximize the chance of fertilization. These are some pictures of embryos developing. So starting with a small egg, and you can see how the embryo is increasing the number of cells all the way to what's called the blastocyst stage on day 5 or 6 after fertilization. And that's the stage at which we can do genetic testing on the embryos, and we'll talk a little bit more about that. So the way in which we are freezing embryos is with a method called vitrification, and this is a newer method of freezing that helps protect eggs and embryos from ice crystal formation. So this is a really critical component that allows higher degrees of success with egg freezing as well as with embryo freezing. Sometimes we get questions of, well, why would you freeze something if you could transfer it fresh? And interestingly, what we know is that if we're freezing embryos, it can allow the future transfer to be a more natural and physiologic environment for the embryo. When a woman is taking injectable medications to encourage the eggs to grow, her uterus is also exposed to those high hormone levels, which it turns out is not the best environment for the embryo. So by freezing the embryo, we allow ourselves an opportunity to do genetic testing on the embryo and get the results back. We're decreasing the risk of hyperstimulation syndrome. And also some studies have shown that for certain subsections of patients, they actually have higher pregnancy rates with frozen embryo transfers. Because when it comes time to do the embryo transfer, it's a more natural and physiologic environment for the embryo. So this just reiterates a little bit what I was talking about. Interestingly as well, there's literature from the obstetric literature which shows that babies born after frozen embryo transfers actually have lower risk of complications such as low birth rate and preterm delivery as compared to fresh. So that's why when we're doing a frozen embryo transfer, the intent, the reason behind it is really to make it the safest possible embryo transfer with the highest degree of success. So with that, I'm going to pause and turn it over to Dr. Chuan.
Hi, everybody. And here we go. Can you guys see my screen, Dr. Friedman?
Yep, we certainly can, Dr. Chuan.
Okay, perfect. I just want to make sure. I feel like I was having a little technical difficulty here. Perfect. So basically, as Dr. Friedman mentioned, I think that it's important to remember that embryo transfer is obviously one of the key steps in achieving success in your IVF cycle. And as she mentioned, there's lots of components that goes into the embryo transfer preparation process. But the first thing that we've done, which is changed from the past, is that we started cryopreserving our embryos and doing what's called a freeze-all cycle in order to optimize the uterine environment. And not to belabor the point, but I think for a lot of patients, they do wonder why they have to have that delay because everybody's super eager to get going, and we understand that. But at the same time, there's been so much research that shows that being able to optimize that uterine environment, making it more natural, more physiologic, does improve implantation rate, so the chance of that embryo taking. Now, obviously, there's other components with the uterine lining that we want to optimize. We want to monitor to make sure that it gets to an 8mm thickness. There's a pattern that we're looking for. And so during your frozen embryo transfer cycle is what it's called, we'll be monitoring that progress and looking at hormone levels to make sure that they're all appropriate. Because what we're really doing when we're doing a frozen embryo transfer cycle is we are mimicking what your body normally does in a menstrual cycle. And during your natural menstrual cycle, between day 5 to 6 after ovulation is when your implantation window is open. So we're going to be able to take over that function essentially by giving you hormones to mimic that process and make sure that you have an open implantation window and make sure that we've selected the best embryo to go into that environment. And with that, we're also looking at personalized protocols. That's an important part of kind of your evaluation, looking at your personal history to see if you need any additional adjuvants that to treat things like endometriosis, or we have patients who come to us with history of recurrent pregnancy loss who we find things during their evaluation that needs to be addressed, or patients with repeat implantation failure. So there are many different personalized protocols, and that's important for us to discuss as a team together. Embryo selection, which I'm going to go into a little bit more detail later, is also an important criteria. And then obviously having an excellent lab to optimize the thaw, the freeze, and just the whole process of embryo culturing is really important. That's why we always, tell patients that part of the magic of what happens with IVF and part of our success rate is greatly attributed to our wonderful team of embryologists and their dedication and commitment to quality. And we also want to make sure that, we create a calming environment for patients when you're going through your embryo transfer, because we know that stress can play a big role in this whole process. And so we have dedicated embryo transfer rooms. When you're doing your transfer, it's about a 5-10 minute procedure. But you will be able to see us. We have a real-time camera that is connected to the microscope, basically, that the embryologist is using to load your embryo. So you'll be able to have that first view of your embryo, confirming that it's your embryo and seeing the whole process of the loading into the catheter and prior to the embryo coming into the embryo transfer room for the transfer. So it's really cool. It's very sci-fi. Patients always say, wow, I can't believe I could see that. It's pretty amazing process. Now, a little bit about the actual embryo transfer procedure. As I mentioned, it takes about 5 to 10 minutes. You do not need to go under anesthesia. If you've had a pap smear, then kind of imagine that that's what that feels like. We basically use a speculum to identify the cervix, and then we put a very soft and thin catheter into the uterine cavity under ultrasound guidance. And so we can see exactly where our catheter is. And once the embryo is brought in by the embryologist and the catheter as well, it goes into that through that first catheter so that it as a guide, and we look at the position, and then we load your embryo into the right spot into the uterine cavity, which is usually in the middle, and you can see here in this image. So I have a little video here. Hopefully it'll play for us. Is an actual embryo transfer that Dr. Park was doing. I don't know if it's gonna play for me here. There it goes. So you can see here, this is an actual ultrasound image of the uterus. And she's pointing out the catheter. And you kind of see that white spot moving. And that's the catheter advancing. And then this whole area here is the lining. See that little bright spot, that kind of flash? That's when the fluid that the embryo is carried in is kind of injected. And the fluid creates this bright spot for us to identify kind of the spot where the embryo landed. And so it takes about 5 minutes, a very smooth and easy procedure. And prior to getting to that part, we're going to talk a little bit about PGT, because that's an important part of embryo selection. How do we pick the right embryo? Most human embryos are actually not viable, meaning that we do waste a lot of embryos. People always think that when we go through IVF and we create an embryo, that automatically every single embryo is going to implant, because we went through so much work to get it to that stage. But I always tell my patients that the embryos that grow to that blastocyst stage by day 5 or day 6 are really like semi-finalists in a mini marathon. We know that if you have a good number of semifinalists, that usually you're going to find a champion in that group. However, science has limitations, and we know that they're semifinalists, but there's not a lot of identifying factors that can tell us exactly which one is going to be your true champion, your true winner. So I think that's part of the reason why even when patients are, in that 25-year-old category and they're trying, is sometimes it could take up to 8-9 months to even a year to get pregnant. And that could be perfectly normal, because we might be creating a lot of embryos that are not viable even when we're doing it naturally. So most do not implant, and there's a natural selection process here. However, typically in the old days, we used to only be able to select embryos based on the way that they looked. And I think that that's helpful to look at morphology, but it doesn't tell the whole story. But it's important to remember that the majority of the time when the embryo does not implant after an embryo transfer, it is due to an embryo factor. And just looking at the embryo doesn't tell us everything about the embryo. And certainly, as Dr. Friedman alluded to, female age and equality are probably the greatest determining factors with regards to embryo quality. So it's important to maximize those factors. Now, in terms of embryo selection, what are the things that we can do to help us? Okay, morphology, we talked about that. Cell symmetry, number of cells. How does the inner cell group look? If you can see this image here, this clump of cells is the inner cell mass, and then the outer group of cells is called trophectoderm. Those are the cells that helps embryos implant. So when the embryologists are grading your embryo, they're going to be looking at both of these cell groups and give them a grade. And we will be talking about that after your IVF cycle. Before you go into a frozen embryo transfer cycle, you're meeting with your physician to go over how the cycle went and what embryos you have and what their grades are. Now, there are other invisible features, and one of the main components that we want to look at are chromosomes. So you go way back to your biology class, and remember that human beings need to have 46 chromosomes. So 23 pairs, we need 23 from the egg and 23 from the sperm to make a perfect blueprint for life. And so during the process of maturing eggs and maturing sperm, there could be errors in this process because we have to go from an immature egg that has 46 chromosomes down to 23. And in that process, the same thing happens in the sperm. In that process of division called meiosis, you can have lots of errors that happen. And as the egg gets older, it becomes more fragile, and so those errors become more prevalent. So that's why it's important for us to be able to see, does this embryo have the right number of chromosomes? So about 10 years ago, people started looking at this technology called pre-implantation genetic testing, which is a way for us to get a sample of cells from the embryo and send it off for testing, and it will tell us whether or not this embryo has 23 pairs of chromosomes, and as a bonus, you can see the gender if you wish. So here you see this image of an embryo, and it's actually in the midst of being biopsied. So what we do is we don't touch the cells on the inside, that inner cell group I taught you about earlier, but actually the cells on the outer edge, which are destined to become the placenta and help with implantation. We could safely extract about 4 to 6 cells, and that DNA can get sent to a genetics lab to get amplified and then to do this testing. And so this is called PGT. PGT for aneuploidy, another term for abnormal chromosomes. And so that's something that we have found to be very helpful for women who are over 37. Why over 37? Well, after about age 35, it's kind of this critical point when chromosome abnormality rate starts going up. And that's why you hear many times, women who are 35 who are still considered very young otherwise, consider advanced maternal age. And it's because of that critical point for chromosome kind of aging. And there's a lot of research that shows that once you get past age 37, over 70% of the embryos that are created are going to be abnormal. And so that's why in this age group, PGT has been shown to greatly improve pregnancy rates and decrease miscarriage rates, because the natural thing that can happen when the embryo is not normal is that nature does not want that to keep going, and so you can have an implantation event but then ultimately have that result in a miscarriage. And so over 37 is when it's truly helpful. I do have patients who are younger, 35, who choose to do it because they know that about 50% of their embryos are abnormal, but medically we recommend it when you're over age 37. Anyone with a history of recurrent pregnancy loss. So there are young women who, are getting pregnant, but they keep miscarrying. Well, it may be that they're creating more embryos that are abnormal than they should be for their age, or that their uterus is not as good as distinguishing an abnormal embryo, and so just allowing a lot of implantations resulting in all these miscarriages when the embryo is actually not viable. So that's an important cause of infertility as well. So it would be very good for that couple to consider PGT to improve their chance of finding the right embryo. Family balancing, we have lots of couples that have a beautiful family, but maybe they have 3 boys already and would love to have a little girl. So this can help with that because we do get to see the last pair of chromosomes, which are the 6 chromosomes. And then there are patients who do PGT because they know that they carry mutations that can get passed on to their children. So if there's a couple that comes in and let's say they've already had a child who's been affected by something like cystic fibrosis, we can do that, utilize that same technique where we biopsy some of the cells from the embryo and do specific testing for that mutation. The parents would have to go through special testing to make sure that we can identify the specific mutations that they carry, but this can certainly be done. And so this has been a great advance for those families that need that. And we do pre-screen our patients to see before they go through IVF if they match up on any of these recessive mutations. And so that's part of your evaluation process when you come in to see your fertility specialist. Now, I kind of touched upon this, that, as we get older, there's more and more abnormal embryos. And so you see in this slide that the younger you are, the more normal embryos you have. And as you get older, past age 42, the chromosomally normal embryos go down to in the 10% range. And looking at this data, I mentioned that, obviously your success rate is going to be higher if you have an embryo that's been tested with PGT. And you see this in this graph here, that if you transfer an untested embryo in someone over 40 versus a tested embryo, you have a much higher success rate in someone who, has created embryo that's passed PGT testing. And so, just to summarize a little bit about everything that we've talked about here, what are our goals in IVF? Well, we want to maximize success rates. So an individualized protocol is an important part of that, because we want to maximize your response, maximize your egg quality. We want to talk to patients about kind of where their personal status is in terms of their ovarian aging, because there's, chronological age, but there's also ovarian age. And there are times when women are young chronologically, but their ovaries are going through some advanced aging compared to their age. And so it's important to identify those women to help them optimize time to treatment, because we know how important egg quality is, and female age is a great determining factor of that. Blastocyst transfer. So there was a time when we used to only be able to culture embryos to day 3, and day 3 embryos really haven't been through as much in terms of development, and so the chance of success was lower. So nowadays we're doing cultures to day 5 to 6 to see if embryos can make it to that blastocyst stage when it has gained the ability to implant. So that allows us to extend that race and to have a better selection for your semifinalists. Okay, and then having as Dr. Friedman said, an excellent cryopreservation program that uses vitrification to optimize, the embryo quality post-thaw. That's really important. And certainly for egg freezing, now that's a reality for patients, when 10 years ago that really didn't work very well. So that's important. PGT screening obviously is another component that helps us with selecting a better quality embryo. And we also want to minimize risk. Close monitoring to make sure that you're not being hyperstimulated, adjusting dose of medications. That's all an important part of what we do routinely to optimize your success. Want to make sure that you're educated about the process, you feel supported, because obviously stress is an important component of this, and when patients don't feel confident or comfortable with the knowledge that they have, that can add to the stress. So that's one of our goals, as well as to make you feel as comfortable as possible. And then the last thing is, we didn't talk about this as much, but choosing, how many embryos to transfer, because we have better embryo quality with the better lab technique, etc. We can opt for a single embryo transfer. And many times patients come in my office and say, we would love to have twins, and can you transfer 2? Can you transfer 3? And certainly there's patient choice in that, but our goal is for you to get pregnant, but then to carry that pregnancy safely through to delivery. And a single embryo transfer is one of the greatest changes that we've made in fertility medicine that has optimized the patient's ultimate success, which is having a healthy baby. And twins are adorable when things go smoothly, but there are lots of risk and complications. And we would talk to you about that. And ultimately, if you decide that you really want to transfer 2, there is patient choice. But our goal is to make sure that we can give you the best embryo quality so that you could choose this safer method of an elective single embryo transfer. And then the last thing that I want to touch upon, the last category, is just lifestyle factors. Many patients come in our office, and that's the things like, what can I do? Because we all do feel helpless sometimes, going through this process. What are the right things? So let's talk about that a little bit. What are the things that you can do to optimize your chances on a natural basis? So one thing, diet. What do you eat? Well, I think that a diet that is rich in antioxidants and omega-3s is super important to optimize health in general, cardiovascular health, brain health. Every aspect of your body is affected by what you eat, and antioxidants and omega-3s are a foundation to that. And a Mediterranean diet is something that we are all very familiar with, and that is a type of diet which is, focused heavily on vegetables and healthy oils, and minimizing meats and sweets. And so I think that following a Mediterranean diet is a good way to get those antioxidants and omega-3s. And what are the things that we know these 2 components can do? Well, antioxidants, they do just that, they reduce oxidative stress to our cells. So anything that's good for your brain health and good for your heart health is going to be good for your reproductive cells. And we have so much pollution in our environment now. So one of the biggest things I always tell my patients to take is coenzyme Q10, because I know that that is a really proven and strong antioxidant, and it can only help you. And sometimes I advise patients to take that long term because it could only help you. And omega-3s and antioxidants have also been shown to improve blood supply and blood flow. Omega-3s is something that people who have heart problems are constantly being told because it could help blood flow. And so same thing here, your testicles and your ovaries need nutrients and oxygen and hormone to optimize function. And so if you take omega-3s, it can help with that. And so those are 2 key components. Usually I'm recommending about 1,000 milligrams of omega-3s a day. You could get that in fish oil or vegetable form. And if you're a smoker, or you have other concerns, other health issues, you're diabetic, taking 2,000 a day would be potentially even better, okay? And obviously you could take supplements, but it's good to find it in your diet too. They all work synergistically together. Things to avoid. Fried foods, things with lots of trans fats, excessive sugar. These are pro-inflammatory agents, and inflammation hurts your cells. So you want to avoid that. You want to avoid seafoods that are high in mercury. Not that fish is great for you, it has lots of omega-3s, but you want to be careful of things like swordfish, which can be high in mercury, and paying attention to that. Try to do organic foods and other healthy habits like avoiding plastics that have a lot of BPA. I think that those are all things to consider. Another big question I get is caffeine. Can I have caffeine? I always say all things in moderation. We do not want to take away the things that you enjoy, the things that you need to function. And so most of us need caffeine to function, but you want to use it in moderation. I would say you could do Starbucks in the morning, but do not do the venti cup. Do the tall. I think that that would be very reasonable. And I think, when we start going to the super size of everything, that's when we get into trouble. Same with alcohol. This is a stressful time. A lot of us use alcohol to help us relax and de-stress a little bit. So we don't want to tell you, no, you cannot have any of it, but use it in moderation. There's a lot of research that shows that, if you're drinking a lot in a day, for women, over 2 drinks a day can decrease your fertility. And I think that's if you have a long-term habit. So we usually try to recommend that you keep it to 4 drinks or less a week if possible, because that's when the research has shown the most optimal success rates. Smoking, I can't say enough about smoking. It's really bad for your eggs, and it's really bad for your sperm to smoke. It just creates a lot of oxidative stress, and we see this in terms of, decreased egg quality, sperm quality, lower embryos, lower numbers of embryos that make it to the blastocyst stage, decreased success rates with IVF, and certainly there are more complications with pregnancy as well, increased risk of miscarriage. So it's important. We know that it's hard. It's not easy. So work on this, slowly work on it, but work on it. And in the meantime, take antioxidants to try to help battle that when you're trying to work through this process of quitting the smoking. Female weight, this is another big one. I know that most of us want to try to be as healthy as possible, but the ideal body weight is about a BMI of 18 to 25. There's lots of research that shows that when your BMI gets above 30, that there is, more risk of complications in pregnancy, more miscarriages, and problems with getting pregnant. And obviously it's not black and white. This is an area of gray, because there's obviously patients who are heavier who do get pregnant on their own. But when we're in the process where we're trying to optimize success, this is an important component that can help. Even if you lose just 5 to 10%, that could be a great help. So we always encourage patients to try to optimize this aspect while they're in the prior to the treatment process, or even during the treatment process. Exercise, another good thing to have in your daily routine for general health. I think it's great, with regards to optimizing your BMI, but also just helping blood flow, stress reduction. I think our goal is about 30 minutes. If you could do that 5 times a week, great. But obviously during your IVF stimulation, it's kind of this conundrum, because as your ovaries grow, we do worry about the ovaries twisting if you're running or doing anything where you're kind of anti-gravity and bouncing up and down. So during that time, you're not going to be able to do rigorous exercise. But still stretching, getting fresh air, walking, that's all still fine. And so we do encourage that. We kept talking about stress and touching upon it. This infertility and stress, there's a well-known relationship. This is like the biggest roller coaster of your life, and sometimes it feels like you just can't get off. So, you know, struggling to conceive is stressful, and we do want to encourage patients to find ways to kind of mitigate their stress. We know it's not going to go away, but finding ways to mitigate that stress is important, because we do know that stress can affect blood flow, cause vasoconstrictions. Now, whenever patients, I always have this joke with them. I say, I know you want to punch me in the face when I tell you don't stress. Of course you're going to be stressed. We know that. But let's find some distraction methods, you know, how to cope with stress. I call them distraction methods because that's what they are. It's just to quiet your brain a bit. And you should find what that is for you. Things you enjoy doing, whatever that may be. Maybe it's going to the beach. Maybe it's rock climbing. I don't know. For me, it's fine motor activities like painting by numbers or going to Color Me Mine. I find that when I do fine motor things, my brain shuts down and that's all I'm focused on. So maybe for you, it's exercising, it's yoga, taking classes, meditation, whatever that may be. Acupuncture is another one that patient asks all the time. I say, if you have a needle phobia, then no. But if you find that when you try the session, it calms you and you feel like it relaxes you during that time during a session, then I think it can be helpful. Absolutely. So you have to find what works for you, but you need to find something. And the next thing, you know, once you do all that is, well, what is the next step? How can I help myself get into that next step? Well, I think it takes a village. So we want you to meet our village. These are embryologists. This is some of our other nurse coordinators, our front office staff. And you've met Dr. Friedman and I, and there's 3 other physicians. I think the step 1 is make an appointment to have a consultation to talk about your specific issue. Doesn't mean that you're jumping into treatments. We're going to talk about evaluations and trying to figure out where your body's at and what makes sense for you. That's the first thing, is the conversation. And then after that, we will dictate a treatment plan if that's appropriate, and we will do an individualized treatment plan. So don't be afraid to take that next step. I know that sometimes I have so many patients who waited forever to make that appointment. You know, with this seminar, attending this, you have a free consultation. So come on in so that we can try to figure out how best to help you. And we look forward to meeting you. And thank you so much for being here with us this evening. We know that, you know, it's an hour of your life, and so we appreciate you spending that with us. And we're here to answer questions if you have any questions. I'm going to go ahead and turn off my share screen and put Dr. Friedman back on.
Hi, everyone. So feel free to, if you want to type in some questions, we're happy to answer them. We're seeing questions kind of come through. And then Dr. Chuan and I will just go back and forth as far as answering some questions. So Dr. Chuan, do you want to take the first question?
Sure. The first question we have is, how much does the process cost? So just to give you a ballpark figure, we do have a wonderful financial team, and we usually encourage patients. Sometimes they can even talk to you before you come in for your first consultation. IUIs usually are in the range of, if you're using oral medications, about $700. If you're using injectable hormone with IUIs, which is another treatment type, that would run in the $2,500 to $3,000 range. And then most IVF cycles are going to, depending on how much medication you need, that also determines your medication cost. But I would say the IVF cycle itself is probably around the $15,000 range, and the medications can range between $6,000 to $8,000, just depending on how much you need and what your personal protocol is. But we do have some great programs here at San Diego Fertility Center. We have what's called global pricing, which means that it includes everything it takes for you to create embryos and then to do the embryo transfer. We have a success guarantee program for patients who qualify. And basically that program means that in your package fee, it covers the whole entire process to create embryos and as many embryo transfers as it takes until you have a live birth. And if you use up every single embryo and you don't have a live birth, then you will get your cycle fees back. So that's a really excellent program for those patients who qualify, and it gives them a lot of assurance.
So the next question I have is about COVID. So we didn't really talk about COVID-19. I know probably all of us are a little bit tired of talking about COVID-19 right now. So I just wanted to answer the question about like what, are we open or how are we handling things with COVID-19? So we did briefly close due to recommendations from professional organizations and locally. We are now back open. We are offering our full spectrum of fertility treatment, including IUI and IVF, but we are doing some things differently. So some of the things that we're doing differently are we are spacing out patient appointments. We are trying to limit the number of in-clinic visits. So for our new patient consults, we are doing it primarily over telehealth, like over Zoom or over the phone initially, and then we're going to follow that up with the ultrasound that's included as part of the consultation. We're trying to streamline and really minimize the amount of time patients have to come see us in person. We're requiring facial coverings for both patients and staff. If patients don't have them, we are providing them. We are screening patients when they come to our center with temperature checks and questionnaires in terms of COVID symptoms. And like I said, we're rotating smaller groups of staff and spacing out appointment times to minimize the number of people that are in our center at any one time as we rigorously disinfect the common areas. So those are some of the things that we're doing to try to maximize patient and staff safety. So we have a lot of protocols in place, but we feel really committed to allowing patients to be able to move forward with fertility treatment, given that we know how time sensitive these fertility journeys are.
Okay, great. The next question is, on average, how many cycles does a woman need to reach success? Well, I think that that's very individual. And I think that's where your patient consultation and your ovarian reserve testing comes in. I would say that there are many patients that can succeed in one cycle, but I think those are the women who have healthy ovaries, who can get a good amount of eggs, in one cycle and create a good number of embryos. And there are patients who can actually, have enough embryos to get pregnant with baby number one, and also have the fertility preservation aspect where they have extra embryos saved for future family building. So I have many patients that come back, for their baby number two, and they have 3 or 4 embryos left over from round one. However, I also have patients that are a bit older, who are in their late 30s or early 40s, who can't get as many eggs in one round, or they get a good number of eggs, but many of their embryos are abnormal. So it may take them a couple of rounds of egg retrieval, and we call that embryo banking, because we're trying to save embryos before we start doing the transfer. And so I do have patients that have to do multiple rounds to try to accumulate a good number of embryos and before we do the transfer. Now, I also have patients who are in the age group who probably got enough embryos in one round to have baby number one, and enough to try at least, but they're purposely doing additional rounds because they know that by the time they're ready for baby number two, their ovaries may not be there, have enough resource for them to reach success or have good egg quality. So they're utilizing IVF then not just to get baby number one, but as fertility preservation so that they have a chance to build their family in the future. Because one important thing we didn't mention is that the uterus does not age the same way as the ovaries do. So your uterus, actually, you can be 45, you can be 50, you can be in menopause actually, and your uterus, we can give you hormones to make it transition it to a state where it could receive an embryo very well. But the key to getting success is having a good quality embryo. So for those women that have poor egg quality, a lot of times we're using an egg donor to create healthy embryos and transferring into their uterus. So by that same token, they have great success rates, the success rates of a 20-year-old. Now, that being said, for patients who are, let's say 39, saving embryos, they could be 42 when they come back, and they will have the success rates of a 38, 39-year-old because that's when they created their embryos. So that's a great thing to remember, is that, there are many different paths to your family, but our goal is to educate you on what are the things that could make sense, not only for now, but for the future. And then it's not uncommon for patients to maybe need more than one embryo transfer. So there's an embryo transfer cycle, is also another type of cycle. So, the goal is, okay, one egg retrieval, create as many embryos as possible, but you're transferring one at a time. So if the first one doesn't take, if you have another embryo, you would do another embryo transfer. So depending on the quality embryo, sometimes you might need a second embryo transfer to get to that champion. So those are all good things to keep in mind in setting your expectations.
So next question, I had a failed cycle at a different center. why would I come to your center, and how would it be different? That's a good question. And first of all, I'm sorry that you had that experience. And really what we see is we do see a lot of patients that have come to us who have perhaps struggled elsewhere, or this may be kind of an ongoing journey that's been going on a long time, or someone may be more at the beginning of their journey. But so, there's a lot of different factors to why a patient may not have success with an IVF cycle. So for us, and we've touched on this in the talk, it's really important for us to come up with a personalized protocol. And I always tell patients, do your research, get second opinions, talk to other providers, because it's really important to find a clinic and a physician who's going to be part of your team, who's going to partner with you in this journey to really help you along the way each step of success. And it's really important that you are with a physician and with a team, with a clinic you're going to feel comfortable. So I think part of our secret sauce that we talk about at SDFC is that we're really, really passionate about what we do. We're passionate about helping people build their families. And for us, it's not one size fits all. It's really about coming up with that individualized treatment plan for each patient. And we love what we do. And so it shows, because, when people are here, they really understand that they're part of our family.
Okay, great. Here's another question. How long do you follow up with the patient? Can I move to another state after doing IVF? Great question. So I'm going to answer it a couple of different ways. So first of all, our normal process when you go through an IVF cycle is that, first we create embryos. So embryo creation is part one. And after that, you do a consult and we go over the embryo transfer. And after the embryo transfer, which takes about a month to prepare your uterus, we check about 10 to 12 days after your transfer to see if you're pregnant. And then after that first test, if it's positive, then we check it a couple of days, your hormone levels a few days later to make sure that the HCG level is rising appropriately. Then after that, we wait about 2 weeks to see if it continues to develop. And then by that point, you'll be about 6 weeks pregnant. And we'll do an ultrasound at 6.5 weeks, 7.5, and 8.5 weeks. And then usually you move on to your OBGYN for the rest of your care. And so typically we're following you for that early first trimester just to make sure that things are progressing well. And so at any point actually during the stage, we do manage patients actually all the time who are coming to us internationally, who don't actually live here, who have patients from out of state who come to us because they know about our success rates. So there's many different ways that we can do this. So let's say you're actually someone who doesn't live in this state and you want to do an IVF cycle with us. Well, you can find a fertility center close to your home that could do the monitoring, but to give us the results, and then we're actually managing your cycle and giving you instructions, and then you would just fly here maybe 3 to 5 days before your egg retrieval, and then we do the retrieval and then you go home. So we do that all the time with our international patients or out-of-state patients. Obviously it's easier on the patient if you live close by, but that can be done. And then for embryo transfers, the same thing can be done. I do have patients who create embryos and then they move. Well, the embryo transfer process requires probably 2 to 3 ultrasounds, and it's easy to manage that, from afar. So again, you would find a clinic to do your local monitoring, send us the reports, we would manage you and decide when it would be appropriate to do the transfer. You would fly in just a few days to do the transfer and you can go home. And it's the same thing with those OB ultrasounds. Those can be done with your local OBGYN as well. So the process, because we're so accustomed to taking care of patients from out of town, it can be very fluid, and it just really ultimately depends on, where you are in that process. Okay.
So I see a question about a couple questions coming in, but one is how can I make that first appointment? So you can absolutely just call our front desk and during business hours, and they'll help schedule you. Or if you want to email our front office, it's kind of frontoffice@sdfertility.com. But if you just call us during business hours, we're happy to get you registered as a patient and schedule that first appointment. So and then I saw part 2 of the COVID question. So I just wanted to finish that. I saw a question about COVID and are we worried about the virus impacting eggs or embryos? So the good news is that there really has been no history of the COVID virus or any virus for that matter impacting egg, sperm, or embryos, meaning being transmitted to egg, sperm, and embryos. So certainly there's absolutely no evidence of any respiratory infection being transmitted to egg, sperm, and embryos. So we are not concerned with risk of viral transmission to egg, sperm, and embryos. The data and the literature regarding COVID-19 and pregnancy, is more limited. So we're obviously eagerly awaiting the studies that are coming out. Luckily, studies so far have not shown evidence of vertical transmission to the fetus, meaning transmission of the virus of a woman who's affected to her developing fetus. Studies are ongoing, but fortunately from an IVF perspective, there is no concern of that virus being transmitted to egg, sperm, or embryos.
Okay. So I have another question here. It says, what is your experience with a patient who has had bowel endometriosis? Well, we do take care of, as a group, women with endometriosis it's very, very common to find that being associated with infertility. So we have a lot of experience taking care of patients who have endometriosis and infertility. And I think that one of the two main things I think that we find with patients with endometriosis is that if they have endometriosis in the ovaries, then I think that it can impact their ovarian reserve and ovarian status and lead to kind of loss of follicles and ovarian aging that's more advanced to their age. So that's certainly one component. And so sometimes we see young women who've had multiple surgeries to remove endometriosis in the ovaries, so they can form these cysts called endometriomas. So that certainly could impact ovarian reserve. So that's one aspect. And then the other is really looking at it can affect the uterine environment and make it more difficult for embryos to implant. So we definitely, depending on the patient's situation, we have specialized protocols for patients with endometriosis where we're worried about, endometriosis impacting receptivity in the uterus. And so there are special protocols that we put you on to suppress endometriosis to improve that outcome. So there's lots of things that we can do to help. And ultimately, I think that if you have healthy eggs and healthy embryos, many of our patients with endometriosis, even with this reduction of uterine receptivity, can reach success. So it's important to come in and be seen and evaluate your ovaries.
Yeah. So and to avoid going over, I'm sorry if we didn't get a chance to answer everyone's questions, but we're happy to answer them individually when we meet with you. So I think we'll pause here to allow you to get back to your lives. But we appreciate you taking the time to join us tonight, and we look forward to talking with you and supporting you in these next steps to build your family.
Yes.
So,
Thanks for being with us.
Bye-bye.
Bye.